are talking about COPD and we are talking about pulmonary rehabilitation, we know that pulmonary rehabilitation has become a standard of care. And there is a lot of evidence that is related to COPD. However, there is very little that is still available with relation to non-COPD disorders and pulmonary rehabilitation. But that does not mean that there is no evidence. We should not forget that. And in this event, we have here with us someone who's working with the WHO and whose basic core interest is into evidence-based practice. Please join me in welcoming Dr. Nicole Pinto. Those who know Nicole will know, some of you know Nicole Pinto as a student, some of you may know her as a colleague. She is very gentle, soft-spoken. She's got an experience which is of more than 15 years. She is graduated from Bombay, India, KM Nair Hospital. She's done her post-graduation in cardiovascular and respiratory sciences. She's worked here in multiple hospitals, which include HN Hospital, which includes, if I have to look into her CV, basically her CV is pretty long. She's done it into, she's gone in further into number of working areas, into clinics as a cardiopulmonary rehab specialist. She joined Pratibha Prabhavalkar in 2012, and till date, she's been a consultant functioning over there in working, looking into the organizational aspects as well as the tele-rehabilitation aspect of it. She went abroad to do her MBA, and she did her MBA in International Healthcare Management at Germany. She has worked with WHO in developing the package of rehabilitation, and she was one of the developers in that for COPD. She's also been the technical working group for basic package for intervention in primary setting. She's looked into finance and management, and she has received the Best Student Award for Excellence in Finance and Management. That's the award she's received from her institute in Germany. So with a lot of credits to her, with a lot of publications, and as a invited speaker, as well as a resource person in pulmonary rehabilitation, I, along with the Society of Cardiovascular and Pulmonary Rehabilitation, invite Nicole to talk to us today about evidence-based clinical practice in pulmonary rehabilitation. Nicole, over to you.
Thank you so much, ma'am, for the kind introduction. It's truly an honor to be introduced by your own professor to deliver a talk. Good evening to all my professors, colleagues, and everybody who has tuned in into this talk. I would like to thank the Society of Cardiovascular and Pulmonary Rehabilitation for giving me this opportunity to speak about a topic that is really close to my heart, and evidence-based clinical practice in pulmonary rehabilitation. So I have structured this talk into 4 sections, and we will be talking about evidence-based medicine and evidence-based practice in terms of what these exactly mean and how can we incorporate it in pulmonary rehabilitation. I will also be showcasing some of the current evidence in COPD and non-COPD patients. And then finally, we will be talking about how it goes, what does the future hold in terms of evidence-based practice and the rehabilitation. I would like to have this as interactive as possible. So there will be certain points where I will be asking your opinions. We'll be having some polls. So please be attentive in terms of just look into the chat on and off, and you may have to switch from one window to the other during the polls. I also have to say that I am actually looking at my screen. So in case due to some reason there's a technical, you cannot hear me, please somebody put on their mic and just let me know if I'm not audible or if there's any issues. So evidence-based medicine and evidence-based practice. I'm sure all of us have heard these terms in our clinical practice. We may have read it, we may have attended talks. So what does it really mean? And I would like your, Manisha, if you could just put the link on the chat. So I request all of y'all to just click on the link which is in the chat, and it will take you to a kind of poll where I want to know what are the first 3 words that come to your mind when you think about evidence-based medicine. So just the first 3 words, it could be anything. Can you see the second screen that I've just shared?
Yes, Nicole, we can see it.
Okay, thank you. So we'll just wait for about 10-20 seconds for everyone to put into their inputs. Okay, so it's nice to see that most of you correlate evidence-based medicine as being scientific, as being research-oriented, and something that's proven. But there are also some of you who have said that it needs to be patient-specific, it gives better outcomes, and yes, it gives a reliable program, effective treatment, proof, validity, and I think someone's even said there's no evidence. So it's interesting to see what all of you have in mind. And what I would like to say is that yes, majority of you are on the right track. So I'm just going to again switch between screens. So by definition, evidence-based medicine, and this is the first definition of evidence-based medicine by Sackett et al. In 1996. And it is the consensus, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So it is basically incorporating clinical research with your expertise to give the best possible outcomes. Now, we've also heard about the term evidence-based practice, and evidence-based practice is an integration of the best available research, clinical expertise, but more importantly, there is another component that's patient values and the circumstance, that is the environment in which the patient is treated and managed. There is also practice management and healthcare policy decision making. So I have another question for all of you, and this time we're going to do a Zoom poll. According to you, is evidence-based medicine and evidence-based practice the same? So I'm just going to launch a poll and it's going to pop up on your screen. So what do you think? Is it the same? Is it different? Or it depends? think we have around 25 participants. Right? Okay, I'll wait for another 5 seconds and then I'll be closing the poll. Okay. So I've just shared the results on your screen, and it's nice to see that 57% of all of you think that it's not the same. And yes, it's only 10% who feel it's the same, and 33% say it depends. And I would actually go with the 33% because to be honest, I have heard these terms used interchangeably. And this is not only in literature, but this is also by very experienced people. But based on what I have read, there are different schools of thought. So some people believe that evidence-based medicine came into account for the medical fraternity, and then when the allied healthcare professions came in, that's when the term evidence-based practice came in. However, I also believe that evidence-based medicine forms the theoretical base for evidence-based practice. So it is the theory which goes with the practice, and they are interdependent on each other. So we cannot separate them completely. There is some link between the two. So how do we use this evidence-based practice in our day-to-day setting? Now, let's take an example that you are running a pulmonary rehabilitation center where you are seeing COPD patients, and it's an exclusive COPD center for rehabilitation. And one day you have a patient with ILD who has walked in and who has requested you for rehabilitation. So you know that as a therapist, you have studied, you are skilled, and you know that the guidelines for rehabilitation remain the same. And you want to take up this challenge to treat this patient. So how would you do it? What you could do is you could use the 5-step model of the evidence-based practice. So you first formulate a question, and the question is, what is the treatment? What is the pulmonary rehabilitation protocol for the ILD patient? Once you have that question, you then start to gather literature. And how do you gather this literature? Today, we are blessed with the internet. We have search engines. You go to Google, you go to PubMed, but you look for guidelines for rehabilitation in an ILD patient. But you could also go to your textbooks. You could also go back to your notes, which when you studied, which when you saw a case, which when you attended a case presentation, and you gather all this literature together. Once you've done this, you go to the next step. And that, according to me, is the most important step of this 5-step model, because that's where your clinical decision-making comes in, because you need to appraise what information you've gathered. And while you appraise, you need to keep in mind about 2 important things. Is the evidence of high quality, and is it applicable to your setting? Now, what do I mean by is the evidence of high quality? Are there systematic reviews? Are there guidelines? Are there randomized controlled trials supporting? But at the same time, while you have to see that it is of high quality, don't get too lost into all of these big studies, because sometimes you may find an answer to your question even in a simple case study. So the important thing is to see, while you read the study, that it is a high quality study. Now, when you come to the application, what we have seen many a times, as ma'am also said in her introduction, that there is not too much of studies in non-COPD patients. So if you take ILD, as we have taken in this example, you may not find too much. Or even if you find, you may not find it in the Indian setting. You're going to find international studies where the settings are ideal, where they have different kinds of equipment. So you may not be able to apply that particular technique. You may have to modify it. That's where your decision making comes in. So these two aspects are very important when you read all the literature that you've gathered. Once you're through this, you apply it. So you have your patient come in, you have your program structured, you send, you do your assessment, and you start the program. And after that, you then do your reassessment, and you have to keep in mind that an ILD patient, in comparison to the COPD patient whom you are an expert, has differences. You have to keep in mind that you have to check the saturation. You have to keep in mind that they may need supplemental oxygen. So when you have done all this, what you have actually done is evidence-based practice. And whether you believe it or not, knowingly or unknowingly, in the past 2 years, each one of us has done maybe not all the steps, but some amount of evidence-based practice, because we all faced COVID-19, which came into our lives, and we had to formulate post-COVID rehab programs. So we have done all of it, and you have already been doing evidence-based practice. So it's not new. Maybe you just don't know about it. So I just want to draw your attention to the screen, and in terms of this flow chart. As I have already mentioned earlier, evidence-based practice is where you have a guidance to make your clinical decision. Now, I would like to divide this complex flow chart into four sections. So we already know that clinical guidelines, clinical research findings govern your clinical decision. But there is also your own expertise, your own experience, which comes from your professional training, which comes from experts, seniors who are working in your setup, that will also drive a clinical decision. However, what is also important is patient values and preferences and societal values and cultures. And this is an aspect which I feel is very important, especially when we deal with rehabilitation patients, because many a times, if you don't align with what the patient's goals are, you may not see your rehab program being successful. So we may see very good in the outcomes, very good improvement in the outcomes, but we are seeing that the patient is not happy because the patient's goal is not an improvement in the 6-minute walk test. The patient wants to probably climb 3 flights of stairs. The patient wants to be able to lift up their grandchild. So these are important aspects, and hence it also governs your decision making. And this is the fourth aspect. Now, unfortunately, many of us do not look always and pay a lot of attention to this aspect. So we have to understand that a patient or a person is only a part of the whole system. So we have to also account in terms of the cost, feasibility, reimbursement, and look at the healthcare system as a whole. And where do we stand when it comes to rehabilitation for the huge number of patients who are who are unfortunately suffering by chronic respiratory diseases in our healthcare system. So this is something to really give a thought and think about as a system as a whole. And I will be talking a little bit more about this in the coming slides. So to conclude this section, evidence-based practice is clinical expertise with the best research available, that is your best practices, and patient values all together, which makes it a successful, which makes it a whole success. And this is what is actually evidence-based practice. So moving ahead to the second part of the talk, which is pulmonary rehabilitation. And I don't know how many of you all have seen this movie, Back to the Future. It's a Steven Spielberg classic. And for those of you who have not seen it, there is a time machine. The car is the time machine, and they usually time travel in it. So there are three parts to it. They've gone in the future, they've gone in the past, and it's quite a funny movie. So I'm here now to take you a little bit in this time machine into the past to really see how pulmonary rehabilitation evolved. So when we talk about pulmonary rehabilitation, and I will be honest, I was surprised when I looked back into evidence to see that it was as early as the 1960s that pulmonary rehabilitation existed. And of course, the studies at those points was just personal observations, just pre-post studies or comparison studies. They were not very structured, they were not of high quality. And why I say I was surprised, because when we studied as a graduate, and even when I did my master's in India, we studied a lot about in terms of theory, in terms of cardiac rehab, in terms of pulmonary rehab. But cardiac rehab was still quite established in terms of practice, but there were very few centers offering pulmonary rehabilitation. And I was quite surprised because when I moved to Germany, it was quite surprising to know that the situation there is no different. So they do have a very good rehabilitation center. And when I moved there, I was looking for a job where I wanted to work in cardiopulmonary. And so I went around looking a lot. And I was quite surprised to know that even there, the number of rehabilitation centers, pulmonary rehabilitation centers, are much lesser than in comparison to orthopedic and neurological. And I always kept thinking as to why, because Germany also, the number of chronic respiratory patients, the incidence, the prevalence is pretty high. So I kept talking to, all my colleagues and everybody saying, and I got mixed answers, and we could definitely discuss that at some point. But what I'm trying to say is that pulmonary rehabilitation is still evolving, even though it backs right to the 1960s. People are still not aware. They are still not giving that much of importance to it. We still need to create more awareness. So coming back to around 30 years later is when the focus on an outcome assessment. So the scientists, the clinicians, the researchers, they developed an outcome assessment. They developed the chronic respiratory disease questionnaire. And this is a questionnaire which all of us use even today. The time test, they realized that we need to document, we need to have these outcomes to see what is the effect. In 1991, was when, as you can see, it kind of picked up pace because COPD started becoming, came into the limelight. They started understanding exercise physiology. There were comparisons between the high and low intensity exercises in COPD patients. There was more documentation, more evidence, and it really started getting pace. And in 1994 to 96 was when the scientists and researchers, and through evidence, they realized that COPD is not just a disease of the lungs. It is in fact a disease of the muscles. And as a matter of fact, all of us therapists, we agree to this because this is what, something popped up on my screen, because this is what forms the basis of rehabilitation, because we cannot change the structural damage to the lungs, but what we actually focus is to try to strengthen patients, try to improve their aerobic capacity by working more with the muscles, the peripheral muscles, such that they are more fitter, and their overall perception of the disease goes down. So that's the whole motive behind pulmonary rehabilitation. And this was also repeated where they did the largest trial And it was a comprehensive trial, which means that they realized that pulmonary rehabilitation is not just exercise training. So we need to do much more than exercise training. And we were going to talk about it in the next slide. And 2001 was when we can say that pulmonary rehabilitation came of age. So what do we mean by that? It was established that pulmonary rehabilitation is a treatment required for COPD, and more research needs to be done on it. So coming to the definition, most of us know the definition by the AACVPR. That's the American Thoracic Society, the European Respiratory Society definition. And the definition of pulmonary rehabilitation is that it's a multidisciplinary, comprehensive approach which comprises of exercise training and non-exercise training in order to get the best expected outcomes, that is, reduce dyspnea and improve the quality of life. So improve participation of the patient, and in turn also reduce healthcare cost for the patient. So this is basically what pulmonary rehabilitation is. And exercise training is the main important crux of pulmonary rehabilitation. And there is a huge spectrum. There is a lot of evidence in what kind of exercise training can be given, that can be incorporated. So I know when I started working at the center here, we used to give aerobic exercises, we used to give resistance exercises because that's what we learned. And then over the years, we have evolved. We have started giving different forms of exercises. There's flexibility exercises, there's focus only on upper limb, there's focus only on lower limb, because it's over the past 10 years, maybe 8 to 9 years is where there's more and more research coming saying, okay, this is a better form of training as compared to that. And you need to be updated with that. Only then can you incorporate it in your practice. So I have put up, this is an interesting study which was done by Professor Trusters and their team, which was published in 2019, where they have given the different modalities of training. As I said, that you cannot give only aerobic exercises, only endurance. You have to sometimes do a mix and match for it. So this study gives you where the evidence as to what kind of training can be given and what kind of equipment is required. So there's interval training. For example, an ILD patient, again, I come back to my ILD example, an ILD patient coming to you is desaturating. So you give the patient supplemental oxygen, but the patient is still desaturating. So do you tell that patient not to exercise? So of course, you need to rule out the red flags, whether the patient is fit for rehabilitation. But after, and this I speak through experience, after you rule that out, you have a cutoff. So you know that below saturation, below this level is not recommended. The patient cannot exercise. So you have a very short range between which a patient can exercise. So what can you give to that patient? So in that case, you can try interval training, have the active phase, have the passive phase. And we have given this to patients, and we have definitely seen that patients have shown improvement. So I want to say that you try different forms of training. Don't just stick to the usual protocol, because pulmonary rehabilitation is also very individualized to the patient. So you will have to change depending on the patient's needs. This is where this slide is also a continuation where you can also give training with oxygen supplements. There's a good amount of evidence. And what I found really interesting, and it is something which needs to be researched, is training with non-invasive ventilation support. And this, many a times, it could be done probably in a tertiary care setup, in a hospital setup where you do have the equipment, because you need equipment. Maybe smaller centers do not have them. And they usually show better results if the patient is a little more acute. So you could also try it while your patient is in the ward. And you can see the effects. There's not enough research. It's something which we need to research on to see whether it actually works on. And of course, there's inspiratory muscle training, which is an adjunct to all your other forms of chest clearance and breathing exercises, which is also very, very, very important part of pulmonary rehabilitation. So to conclude this section, as I said, that the pioneer era, so pulmonary rehabilitation backs right to the 1960s, so it's not something new. And the pioneer era was up to the 1990s, after which it picked up a lot of pace. It is a multidisciplinary, comprehensive approach. It helped to reduce symptoms, optimize functional status, increase participation, and in turn reduce healthcare cost. And finally, remember to use different forms of exercise training while designing your individualized program. So where do we stand in terms of current evidence of COPD? Ma'am did mention that there's a lot of studies in COPD, but we don't have enough studies in non-COPD patients. And that is in fact true, because there's a reason for that. So if any of you paid attention to my the history slide, it was COPD which was the focus, and they did a lot of studies in COPD. And I remember even as a student, when we had to think of research topics, everybody wanted to research in COPD, effect of balance training in COPD, effect of agility training, effect of the ADL. So COPD was the patient group, because it's also that there are a lot of COPD patients. So when you're doing your master's, you also want to see what is easily available. And I don't deny that, because I had a topic where I had to really look for patients and it was a struggle. So coming to the COPD, so the standard is the Global Initiative for Chronic Lung Disease. So this is the GOLD, as they call it, and they come out with a report every year, and it is usually, if I'm not mistaken, a free access. This report studies COPD and gives the latest updates for the disease condition as a whole. So you're talking about the medical management, the rehabilitation management, also the aftercare. So it gives you guidelines on what is the evidence and the level of evidence, in fact, for all of this. So, and it updates, if I'm not mistaken, every year. So this is the 2022 report. And if you see in the first section, where it says pulmonary rehabilitation improves dyspnea, health status, and exercise tolerance in stable patients, it has evidence A. It has the highest level of evidence. It has 1A evidence. So what does that really mean? It means that it is the gold standard for rehabilitation treatment. So it means that when a COPD patient comes to you for treatment and you give them their medical management, you have to also prescribe pulmonary rehabilitation. It has the same level of evidence. That also shows that now the researchers have reduced researching on these aspects. And in fact, they have moved to the second and third. So they have moved to, when it comes to rehab, I'm talking, they have moved to what is the how effective is patient education, how effective is smoking cessation, how effective is self-management, how effective are patient support groups. So they have started researching on these, because there's not enough, it's not yet reached the high level of evidence. But what was also interesting is this year in the report, they also added another section, which was integrated care programs. And thanks to COVID, we know that tele-rehabilitation is an option and we can deliver it to the patients. But they have seen that there is not enough evidence which is supporting that it has demonstrated equal effect. So what does that mean? That means that, yes, you can have tele-rehabilitation for patients, especially when we are in a city like Mumbai, where it's maybe not possible due to various constraints like traffic and all of that to reach a center, or you don't have a center, especially looking into the smaller towns where you don't have a center. So you have somebody sitting in Mumbai who has a satellite center offering tele-rehabilitation. So you do have, when in such a case, it is definitely the best option because some treatment is better than no treatment. Some rehabilitation is better than no rehabilitation. But tele-rehabilitation should not, I would say, should not replace your in-person rehabilitation because the benefits are proved of in-person, and it also gives it's a sense and feeling of belonging to the patient. So how is it when it comes to non-COPD? As we have already discussed, now when it comes to non-COPD patients, there is researchers are more and more interested now in non-COPD. So you do have evidence and research coming up for ILD patients, coming up for pulmonary hypertension, coming up for bronchitis, coming up for lung cancer, coming up for all different chronic respiratory diseases. And I do know that when I was doing my master's, and I had a keen interest in ILD more than COPD, because and I always wondered as to why is it so difficult to, why are there no studies? And then once when I was having a conversation with a chest physician, they also said that it's because of the nature of the disease. And it's not wrong because it manifests very differently. It's just a huge spectrum. So it is difficult to have control groups. It is experiment to group sometimes a patient because you may not have all similar cases. You may have one of different types. So that's where it gets difficult, but it is not impossible. But what I want to highlight here in this slide is if you look to your extreme right, in terms of the duration, in terms of weeks. So when we usually prescribe, and this also I'm saying through my experiences, this is what I have done in the past, and I have realized that we usually used to prescribe and we used to tell the patient, okay, you have to come for a minimum of 8 weeks and then you see the effect. You will start seeing the effect, And so patients used to come in for 8 weeks, and we used to say this to all the patients. But when I saw this, I realized that it's not a one size fits all. So you do have to give certain disease group patients maybe a little longer duration of exercise training as compared to some others to really see the outcomes. And this is what drew my attention in this study. Yes, there is also different intensity, frequency, and all of that. But this was something which I just wanted to highlight. So we should not just prescribe the same thing blindly to all the patients. We need to see what evidence is saying, and accordingly, maybe structure our programs in our centers. So the COVID-19, I could not put a slide on it because we have now also started with post-COVID-19 rehabilitation, and there's of course a lot of evidence coming in. There's not too much of high level because it's still in the very nascent stage, but we do have recommendations, and I would strongly recommend those who are into post-COVID-19 rehabilitation to refer to the Clinical Management COVID-19 Guide. It's a living guideline by the World Health Organization. It is also free access. And what does it mean by a living guideline? It is updated from time to time. So here again, it's a complete report, but they have a dedicated chapter for rehabilitation. And it is so beautifully put because they have separate sections like rehabilitation and fatigue. Rehab and what are the recommendations? Then they have rehabilitation and service delivery, means what are the different forms of delivering rehab, what could be given, and the recommendations for that. They have rehabilitation and going back to work. So there are different subsections, and it is quite interesting to read. So for those of you who are keen, please refer to this guideline. It's freely available. So to conclude, in terms of evidence, as I've mentioned, pulmonary rehabilitation is the gold standard treatment for COPD. Means it should be included. We need, if we don't still have referrals, we need to create more awareness. That is our job as therapists, to create awareness, to let chest physicians and those practicing and the specialists also know that yes, the patients require rehabilitation. There's also a good amount of evidence supporting rehabilitation in non-COPD patients. So we don't need to really restrict. And I know as therapists in the centers that I have worked, we don't restrict to COPD. In fact, sometimes we have more of non-COPD patients, because the COPD patients, usually it's only during the exacerbation that they feel that there's a problem. So they don't really follow up as much as probably an ILD patient. And lastly, use validated databases. They are easily available. It's become more easier to access them for updated guidelines on current evidence. Yes, so we have come to the last section of my talk, and I know I have given you a whole lot of information to take in, and the question is, as you can see in this cartoon, so the latest research shows that we really need to do something with all this research. So what exactly do we do with all of this? We have everything. Okay, we are using it, and how is it going to be in the future? What are the numbers? How exactly are we going to really, maybe it's easier said than done, that evidence-based practice, but can we really do it? Well, the answer is yes, you can do it. I do it. It starts from the individual level. So if each individual can do it, you can definitely make a change. We now, in this section, I want to go a little bit into numbers and a little bit looking at the whole system. So as I said, that is the fourth aspect to your decision making. And there is where you need to be aware in terms of how we stand, where the chronic disease burden is. And these are numbers from a 2016 report. So it is relatively old, but if it tells you the chronic respiratory disease burden in India compared to global, and it was in 2016 almost 16%. And I've not put it on the slide, but in this study they have a map, and they have shown different areas in terms of colors and how it was in the 1990s, and so it was a complete blue zone, and we were very well spaced. And in 2016, everything is red, meaning that the prevalence, it just went up a lot. There are a lot of reasons for it. It is a whole different set of discussion. But this was a 2016, so we can only say that these numbers have gone up quite a bit when you talk about the entire chronic disease spectrum. And just a few days ago, we celebrated World COPD Day, and there was an article in the Times of India where we have seen where they said that this is a study which is published in Lung India. Yes, in fact, last year. And it was estimated that 7.4% have chronic obstructive pulmonary disease. So this is just pulmonary disease. They have not accounted for the other respiratory disease. So what I want to say from this slide is that we do have a huge chronic disease burden. And this was the reason why when I moved, and even when I was in practice, and when I was here in India working, and even when I moved, the little period that I had while I was transitioning, I always used to think that how is it that I could do something more in order to impact this disease. So how is it that I can help in my small way, to understand the whole system? And at that point, I decided to do my MBA in international healthcare management. And the reason I took up this course is it gave me an understanding of global healthcare systems. And this was really an eye opener for me because I understood how systems work in different places. And I always compared it to India in terms of how we could improve and how we can incorporate and how we can get it better. So at this point, after having heard me, I would like to know your opinions. So Manisha, we could just give me a moment. So we're again going to go back to the same link. So we will reshare the link. I'll just stop my screen. I'll stop sharing. And so Manisha, I think if it's possible, please could you resend the link? And I have another question for all of you. Is what is your opinion on evidence-based practice in pulmonary rehabilitation in India? I know a lot of you are practicing therapists. Some of you may be studying. Some of you are very experienced in the field. So you do have a short text box where you could just write your views. It just to understand that what do you think? So I in the past 30 minutes we've discussed different aspects. So maybe if something was new to you, how do you think it can be incorporated? What do you think? Where do we stand in terms of evidence-based practice in pulmonary rehabilitation in India? Is the link sent?
We can see the question on the.
Yeah, so you need to reshare that same link.
I did share. I'll share it again.
Yeah, I've got one input, so I think it's working.
Yeah.
Any more inputs? Or maybe would you all be more comfortable putting your mic on and sharing your opinion? Yes, I do agree. And whoever has written this, that documentation is important. It is very, 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 very important. I have learned one thing, that if it is not documented, it is not done. And I cannot stress enough on how important it is to document. So documentation is the first step to doing research. The next is to put them all together, analyze, and then to publish. So still in the infancy with poor infrastructure, yes, unfortunately, that is the situation we are in. And I also agree that we have a lot of convincing, especially in tier 1, tier 2. Yes, that's true. Cultural differences is also a huge factor, especially when we live in a country, when we're living in India, where we have so many different cultures that exist. There are very few evidence regarding pulmonary rehab patients. Yes, awareness is better. Patients are more regular with follow-ups, but still dependent on chest physicians. Many physicians still feel walking as a substitute to exercise and should be educated. Yes, so we need to have a awareness programs for physicians. I do know that there are workshops conducted for them, but I also believe that it needs more than them understand. They do understand what rehab is, but more than them learning the different concepts, probably are at on regular intervals, if we have awareness talks like how we are doing right now, where we have physicians who can come in and have a discussion, so that would help. The yes, high quality. Totally with you, high quality studies with Indian population. We require them. We are also doing studies, but unfortunately they are of the lowest evidence. So they're still retrospective studies. We are not doing prospective studies here. So that's something which we definitely need to work on. Evidence-based practices. Therapist, yeah. So someone has really raised a very important point, and maybe the professors here could take note of that. Is that we need more emphasis during bachelor study and awareness about the same. I'm not sure in terms of the syllabus how it is right now, but I do know that when we did our bachelors, we had a very small. We were just introduced, I think, to. So yes, it would definitely help to have that. And problem solving approach towards new interventions and device. Yes, definitely. So thank you so much for your opinions. I am going to save this and I will probably share it with ma'am and the team, so you all can have it also. So let me just share and go back to my presentation, which is. So this is something that I want to share, which is my recent work. It is still work in progress. It was I looked at the Indian chronic care rehabilitation system. So I want to specify this is not only respiratory conditions. It's the complete chronic care, chronic diseases. And I did a little survey and spoke to certain experts in the field, and it was more a qualitative study, is what I could say, where I looked up research about the rehabilitation system in India and how is it structured. And through my analysis, I came up with what are the strengths and weaknesses in our system. Unfortunately, we had more weaknesses than strengths, but we do have a lot of strengths in terms of we have a very good education system. We have a lot of skilled therapists. The problem is the skilled therapists, they move abroad, and of course then we lose that, but that's where it goes into the weakness. But we still have because of our education system and because of also the growth, especially and this I'm talking about tier 1 cities, so you're talking about your metropolitan bigger cities. We have established rehabilitation centers, so there are quite a few rehabilitation centers that exist, and also with advanced technology. The question is it affordable? So unfortunately, our insurances don't cover rehab. I'm not sure if they have started, but that's another change which needs to come in, where we need policy makers to to vouch for that, to speak, but it is difficult. It is not easy to make change at such a high level. But I know through all those who have spoken, I spoke with different stakeholders from different aspects, and there is work being done towards creating awareness. But at the individual level, we can definitely try to be more updated. We can definitely try to create more awareness. We can definitely try to form a structure and try to form a uniformed base of rehab. So by that, what I mean is that if there is a patient who is going to a center, say, for example, in Bandra, and a patient who is from, say, from the eastern side, say Thane, and a patient who is like in Borivali and in town, we should try to have a uniform system of rehabilitation for which we need therapists to come together to formulate this program. I know it's easier said than done, but it is not impossible. We can definitely do it. And as therapists, if we get united, then we can then approach and go to the next level. So that is something which I feel can definitely make a change to what the scenario and improve it. It's small steps which will eventually lead to a bigger success. So to conclude, the future of rehabilitation, well, we have seen the numbers. We know that there are a lot of cases. We know that we have skilled. Yes, maybe it's not at par with the amount of patients, but we do have skilled. So we need to engage patients in better tailored program. So structure your programs based on evidence. We need to create awareness and train healthcare professionals to deal with the individual needs and preferences of patients. We need to incorporate innovative approaches in delivery of services. So like how we did it during COVID times, we had, everybody went online, everybody went to tele. So we have to try and see if we could still do it so that we can reach out to places where we don't have these centers, so whether we can reach out to these patients. And finally, continue ongoing research, documentation, and publication. We have something here. It's not something to be proud of, but unfortunately, we have a lot of patients and a lot of patient population here. And I know this through experience that we learn maximum from our patients. We gain the maximum experience while we are in connection with our patients, with the rehabilitation, when we speak to them. In fact, many a times we as therapists spend more time with these patients and as compared to chest physicians, and they form a certain bond. So we can definitely have a little amount. If we are just motivated enough, we can definitely do research. We can definitely do more documentation. We can definitely do more publication. And I want to stress on this because while I am sitting in Germany, and when I speak to my colleagues and I do tell them of what great work we are doing, I do have few people who do come and say that, okay, then why are you all not publishing? Why is there not enough evidence? Because the world sees what is documented. And unless we document, the world will not know what we are doing. And I want to say that there is a lot of interest now with researchers in low and middle income countries. So everybody wants to know what is happening. So we just need to step up and be more motivated to conduct research and publish. And I'm sure the future will definitely be very bright for us. On this note, I would this is my final slide, and keep those thinking caps on. Do not be so busy in your regular work and your daily practice that you forget evidence-based practice. Take some time sometimes to have case studies, take some time to attend conferences, take some time to attend workshops so that you update yourself, so that you see You connect with people all around. You connect with your peers and colleagues in different locations. Exchange of views. That's where we grow. That's how I have grown. That's how I have learned, and that's how I'm sharing my experience here. So on this note, I would like to say thank you. If please do feel free to connect with me on LinkedIn. Just send me a one-liner in the chat that you were part of this discussion, and I'll be happy to connect. So thank you very much. And I am now open to questions. I'm not sure how we are on time, but yes.
Yes, we are definitely on time, Nicole. And thank you so much. The presentation was really wonderful. I'll just quickly move on to the first question.
Mm-hmm.
How effective is online pulmonary rehab? Which cheap, reasonably priced measuring monitoring equipment can be used? Asking for our patients from non-urban areas.
Okay. So the first part of the question was how effective
is online pulmonary rehab. I think they're talking about tele-rehab.
Tele-rehab. Okay. Yeah. So it is effective. So like as I mentioned in the gold standard slide, that in terms of evidence, we don't have very high level evidence that it is as effective as in person. So when you talk from the research standpoint, but that said and done through personal experience, I would like to say that if you don't have any form of treatment, then yes, online is definitely the way to go for your patients. And there was a second part, I think, which cheap equipments?
Yes.
Yeah. So in terms of equipment, so for rehabilitation, you need
monitoring, yeah.
For monitoring. So you need your basic equipment. You need your stethoscope, you need your BP apparatus, you need a pulse oximeter. So these are your basic equipment which you need in terms of monitoring. So if you have this, I think it should be good enough to monitor the patients. Yeah.
What outcome measures do you use for assessing muscle strength in pulmonary rehab, upper limb and lower limb strength?
So you're asking me, is this just a general question?
Yeah.
Okay. So in terms of upper limb, so for muscle strength is what we typically use is the the 10 RM is what is used for muscle strength, and for that's for upper limb as well as lower limb. But there are also new endurance. Is that, sorry, just
so this is related to pulmonary rehab, I think. So in our patients, what outcome measures can we use for strength assessment?
For strength assessment.
Yeah.
So what is very, very easy to use is your 10 RM strength assessment. So that is something which we practically use. So that's also for upper limb and lower limb. I mean, I am not sure if there was anything more specific, but there is also, if you have the equipment, there's also the 1 RM which you could use. But that requires you to put the muscles into different positions, and it may not be suitable for respiratory patients because of their condition. So I would recommend that to go by the 10 RM method of muscle strength testing. Yeah.
If a patient has low EF, then what precautions should we take during pulmonary rehab?
Okay, so this is something which I would say.
Is this, I'm sorry, if patient has EF reduced moderate to high level, can Ms. Parab, can you just ask the question yourself? Is it ejection fraction? Is it something else?
Ejection fraction.
If patient has EF reduced moderate to high level, then what precautions should we take during pulmonary rehab?
Yeah, so I think is
Ejection
in
level.
terms of
Yeah,
percentage, yeah. So
yeah.
the ejection fraction. So we would need to be very careful with these patients because they definitely have a cardiac involvement too. So I would definitely first see and rule out whether we can give rehabilitation in consultation with the treating physician. But if they are referred, you definitely need to have a cardiac monitoring while you are giving, and by that I mean the telemetry monitoring, the ECG monitoring, along with rehab. So typically a pulmonary rehabilitation, a respiratory patient, you do not need continuous telemetry ECG monitoring. But if a patient has a low ejection fraction, they come into the high risk, and there could be a relative contraindication also. So you need to be very, very careful. I would say you need to do it with telemetry monitoring for sure, but after you have ruled out whether the patient is fit to it.
The next one, any differences in pulmonary rehab practices you have experienced in Germany and India?
Okay, so that's a nice question. So, so the setup I work in is more of we do see pulmonary patients, but it's not a dedicated pulmonary rehabilitation setup. It is more of cardiac and orthopedic and other chronic diseases. However, we do have a lung group that exists. So when you talk about rehabilitation system and you compare India and Germany, I have to say that there's a huge difference. It's the whole system in Germany is very different because they have a concept of inpatient rehabilitation that exists in Germany, wherein once the patient is discharged from the hospital, they go to a rehabilitation center and they are there for their 3 to 6 weeks, 3 to 8 weeks for their rehabilitation. And they're usually, it's like they call it a cure. So they call it it originated from the spa areas. So they have a place which is more in the outskirts. So it's more where the countryside, where, you get fresh air is what they say. So that's where they undergo rehabilitation. In my setup, the pulmonary rehabilitation, they do more of we have two groups who come in, so they do more of group exercises. They do not structure it as specifically in the way we structure it in terms of doing in terms of the therapist doing a 6-minute walk test, because they already come in with an ergometry test result. So they come in with an ergometry test, which is done by their physician, and we use those same parameters and we give them training on the ergometry. So we don't do our own assessment. We actually have to follow what is being given. So to answer the question is, there is a huge difference in terms of the delivery, but the goals are the same. They don't have a dedicated strength training. They do more of group sessions. But in terms of outcomes, I have seen that, yes, it is effective. It's equally effective. So the patients do feel better. But that said and done, I see more of cardiac patients as compared to pulmonary. So hope that answers the question.
Okay, the next one. Does IMT work as effective as peripheral strengthening as an adjunct therapy? Probably in pulmonary.
Okay. So I have to be honest on this. I do not have experience with inspiratory muscle training hands-on. It's just what I have seen in evidence. So I am not the best person to answer this question. And in terms of what exists, they say that yes, it is helpful, but it cannot replace peripheral muscle training. So, but I'm sure there will be a lot of you who are more experienced. Maybe Manisha, if you have worked with that, maybe you could chip in into this answer, because I don't have hands-on experience in IMT. Yeah.
Yeah, so inspiratory muscle training is being used a lot nowadays, but it cannot replace your peripheral muscle strengthening, as you said, because both have their individual roles. One is for your breathing muscles, and one is obviously peripheral strengthening, which is very important in these patients, as we see a lot of patients having muscle loss, peripheral muscle loss. So it both are required. IMT is an adjunct. Strengthening exercises are an important component of pulmonary rehab that cannot be replaced. I hope that answers the query. And I'll move on to the next question. When you see arrhythmias in COPD, basically anything to be kept in mind while rehabilitating such patients?
So it depends on the level of the arrhythmia in terms of the grade. There again, I would say that you need to consult with, and because some of them have just silent, which are not managed, or they do not know about it. So it would be good to have a telemetry monitoring. So that is these patients, I would say, it would be good to have them also hooked up onto the ECG. So that is something. But otherwise, if they are asymptomatic, you can carry out your treatment, because the fact that they are coming to you means they have been, as long as they have a go ahead with from their therapist, from their physician, sorry, to treat for rehab.
I agree. Acute arrhythmias is, I think, something that needs to be kept in mind. You can not really proceed if it's something acute, but if it's chronic, they're used to it. So you can do a good monitoring and continue with the rehab. Okay. What can be included in patient education so that the patient have the insight about the importance of pulmonary rehab?
So that's another area which is really close to my heart. So I like that question. So patient education, very, very important. And this is something I can tell you from my practice in Germany. So there is every patient who comes in has a plan. They have a plan. And so usually when they come in for rehab, they come in for a certain, so this I'm talking in my setup, which is an outpatient setup. So they come for a rehab from 8 in the morning, and they are there. They're different groups. So there's from 8 in the morning to 2 in the afternoon, they are in the rehab setup. And they have different things. So they have a slot where they do the aerobic exercises, they have a slot, and they have a patient education session at least twice a week. They have counseling, which happens once a week. And the ones who really require a one-on-one have it more often. So there are different topics for patient education, and I feel that we do not do it as much here in India. We need to, but correct me if I'm wrong, I'm not sure if it started right now, because this I am talking when I was practicing, that there were not so much of education sessions. What is the kind of education that you can give them? Very, very basic. You can start off with just what is, for example, the COPD, what is the different lung conditions. You can explain to them in simple words, how is rehab going to help them? You can explain to them why is it important to have a support group. That could be one topic. You can explain to them how can they have energy conservation techniques. What is this? So that's one topic. So there is also, if I'm not mistaken, a list. So if you check the ATS or the BTS, they have a list of education topics, but they are more for the Western environment. But you can definitely take that list and change. But yes, patient education is very important, and it should be a part of your rehab.
One last question, Nicole. And after that, any further queries, we can just answer them. You can just mail it to us and we can reply to you all personally. How often should an individual follow up with a therapist once the recommended week of rehab is done?
So it depends on the patient. I would say that you, rather than the recommend, so don't don't stop completely if the patient can still come to you, because long-term effects are also important. So what you could do is, suppose the patient has finished 12 weeks of rehab. After that, maybe instead of coming thrice a week, you could reduce it to twice a week for a month, and then eventually once a week. And then you could follow up maybe you have now the option of tele, so you could follow up maybe once a month, once in 15 days, and they could come once to the center. But if they can continue coming to the center, then that would be best, because you do see definite improvement in the initial 12 weeks, but you also need to maintain that, right? So the longer they come, the better they will feel. But you do a graded approach if possible. Don't suddenly stop, because we are all human at the end, and we feel better, we will stop doing exercises, we will come back to square one. And this is even in everyday practice. All of us go and exercise, and you go for a holiday, you come back, you need a sort of motivation just to get back to exercises. So yes, so do a graded approach if possible.
Thank you so much, Nicole. It was indeed a very interactive session and a lot of pointers to take home. How evidence-based medicine and evidence-based practice can help us. How does evidence-based medicine basically from the theoretical aspect to evidence-based practice? What is pulmonary rehab, the different modalities of training, how important it is to document whatever results we find out. And definitely the most important take-home message is trying to form a uniform system of rehabilitation. And I would just highlight that's the entire goal of this society too. We are here to form a uniform common goal of all the cardiotherapy pulmonary therapists together, to bring them together, improving standard of care, spreading education and research, strengthening our research, increasing the visibility of our aims, and networking all members together. So do join us. The email ID, you can send in your queries in the email ID and join the society. The link is there on our website. And thank you so much for this insightful session, Nicole.
It was a pleasure. It's my pleasure. Thank you so much, Manisha, for all the support. And yeah, thank you everyone for joining.
Yeah, and I would like everyone to just switch on their cameras for a few seconds so that we can have a group pic. I think it's done. Maria ma'am, would you like to just say something?
Just looking forward to getting, the support from everyone, so that what we are aiming and what we started off with, our common goal of standardizing our practice and having recognition of cardiopulmonary therapists together. It's only unitedly that we can do it. We are right now a handful of us, and we look forward so that we can streamline all the centers, all the therapists. We have inputs from each and every therapist, urban and rural, to what could be the standard of assessment, standard of practice, taking our whatever lacuna that we have. We don't have that great infrastructure, but within what is available, how to do the best, and that should be our goal to come together. So I thank Nicole for a very insightful lecture, and she actually took through the whole journey of the evidence-based medicine and evidence practice, and also address the components of pulmonary rehabilitation. So thank you once again. Maybe we should also call you on finance and marketing of how to go about it and how should physiotherapy be promoted for it.
Yeah, sure. I will be happy to give my input on that. But thank you so much for having me. It's been lovely. Thank you.
Thank you. So thank you everyone for joining us. Have a good day. Bye.
Do send us your feedback on our email ID, cvprsociety@gmail.com, and follow our Insta page. And I would like to announce that today we completed 500 followers on Insta. So it's a good start and hope we have more followers. Thank you.